Hello, my name is Sam Farah. I'm a vascular surgeon from Melbourne Vascular Associates, and this is a guide for patients on venous disease and varicose veins. Now, just the usual disclaimers, please see your specialist or have a chat to your doctor about your specific condition. The advice and information given here is general in nature. Varicose veins can present in a number of ways. Sometimes the problem presents quite early with spider veins and reticular veins. These where the veins can be quite small, all the way to advanced or more advanced disease where we have what we would call a venous ulcer. Varicose veins are very common in the general community. Perhaps up to 40% of adults have some form of vein issues that could be identified if you look at their legs or their body very carefully. And it's certainly a problem more common with women and as we get older. Going back to this slide, we have several stages of vein issues. We go from C1 all the way to C2 where we have more prominent varicose veins. And C3 is often when people will come to see us for the first time, when they notice some swelling that starts to develop around their calf and ankle. We can also then get C4 changes where we start to get some skin discoloration related to the vein issues. And C6, as I've said in the prior slide, is where we have more advanced changes where we have a venous ulcer. So why do vein issues occur? The underlying issue, or what we would say in medicine, the pathophysiology, is that the normal function of the veins has failed. The job of the veins in the leg is to return the blood upwards against gravity back to the heart. Now, there's no heart muscle in the leg, so the way the blood gets there is with contraction of your calf muscles and thigh muscles that propels the blood upwards because the veins sit within the muscles. And then in between muscular contractions, if blood wants to go with gravity, these valves here close and they prevent that from happening. When the valves fail, and it's usually because we inherit our veins from our family members, so most people can tell me someone in their family that had vein issues, the blood no longer just goes upwards, it goes upwards and then back down. And by doing that, we call this reflux, and by doing that, the blood stagnates in the calf and around the ankle and in the lower leg and causes a range of issues, as we've seen already. Here's an ultrasound that I captured during a varicose vein procedure where we can see here, I'll highlight the vein wall here, and there's another vein wall here, and this area here that you can see, this is one of the valves in the veins. And here is the valve corresponding to that on the other side of that vein. If I run through the video, what you can see is that within this vein, the valve kind of sits closer to the edge and doesn't reach across very well with its corresponding neighbor, and is really not allowing adequate closure to prevent blood going back towards the foot. Shown in another way, a healthy valve allows the blood to go easily upwards towards the head, and the valve's closed to prevent the blood from going backwards. Whereas here, in a vein with poor valves, allowing reflux to occur, the blood is going down towards the foot. So that's generally what we call reflux. This causes venous hypertension, which means excessive pressure in the venous system of the leg, and this can cause a number of issues: pain, edema, i.e. swelling, and as we've seen already, skin changes and ulcers developing. Now, interestingly, within the leg, we actually have two venous systems. We have a superficial venous system, and here we have a deep venous system. The deep venous system is where people get clots, DVTs, and some more unusual vein problems where they somewhat can present with slightly different issues. Now, we can get reflux in the deep veins as well, but by and large, most of the reflux we see is within the superficial venous system. Particularly this vein, the great saphenous vein, it's a slight mystery in medicine to why it happens, but the great saphenous vein is the vein that generally demonstrates reflux first. And so instead of the blood going upwards, as we described, back towards the heart, blood's now going down towards the foot with gravity. And from that vein, we fill other veins around the calf and the ankle, and even sometimes up in the thigh. Now, there are other veins in the lower leg that can cause issues issues, particularly small saphenous vein, and also this anterior accessory saphenous vein can also have some problems as well. But by and large, I would say 60 to 80% of first presentations are just due to reflux within the great saphenous vein. Here's a resin mold that was taken of someone's varicose veins, and we can see this really amazing pattern. We would have reflux in this vein, which this would be the great saphenous vein here, and then from this vein you see all these other branching veins, and particularly they can get more and more fine as we get closer to the skin. And this is where people often will present with varicose veins or spider veins around the calf and the ankle. It's actually filling in a top-down fashion from above, again following the path of gravity. I think this is also why sometimes when people will see someone who's not experienced in this area with spider veins around the ankles, they can have an area like this injected, but without having the top treated properly, the blood will find another path to follow and then cause issues elsewhere. And that's where people then come back and say, I had the injections done, but they came back worse elsewhere. When you come in for your initial assessment, you'll basically be examined by the sonographer, who's really just trying to map out where the vein issues are occurring. So in this patient, we would have found there would be underneath here, we would have had the great saphenous vein with reflux feeding these calf varicosities that she had noticed. Now the treatment for vein issues are basically, or more specifically varicose veins, is to close these bad veins. So go back to the previous slide, if I just remove some of these markings here. If we identify reflux within this great saphenous vein, so the blood's going the wrong way, what we would like to do is close this vein so that the blood no longer follows this pathway, and then the blood then takes the better veins to get it out of the leg. So what we'd like to see when you come for your follow-up ultrasound is that this great saphenous vein is closed. There are two main ways that we like to do this. Now, if you go back to this slide, you may notice that if you look carefully or use your imagination, you could think that this looks somewhat like an upside down tree. We've got the main trunk here, and these could be or seen to be leaves and branches from the tree. So we really want to apply something really durable and reliable to this main trunk, and we have slightly different treatments when it comes to these veins, which are often near the skin. For the trunk, we would consider two main treatments to be superior currently. Right now, RFA is one of the most common treatments done in Victoria. It's a very reliable heat-based treatment to treat varicose veins, and would probably account for 75% of all vein treatments done in Victoria or thereabouts in the last 12 months. There's a slightly newer and lower pain option called Venocil, and we'll talk about that later. Laser is still done, but not as often as RFA because it has some technical drawbacks associated with the procedure, particularly associated with laser safety, and its side effect profile we think is a little bit worse. Stripping is still sometimes done, which you may have heard of, but the results for stripping versus a minimally invasive technique are basically equal, and because of that, most people would often prefer to have something done minimally invasive if they could. For the veins closer to the skin, mostly we do sclerotherapy. Sometimes we talk to people about surface laser, and for some of the larger veins, again around the skin, sometimes we do phlebectomies where we pull the veins out, or sclerotherapy again. I would say sclerotherapy for the surface veins, by and large, would account for 90% of our treatments. So to summarize, for the trunk, we would either choose RFA or Venocil, and then most people would then have sclerotherapy at a second stage. Now, just to emphasize the point, the sclerotherapy we generally do at about 8 weeks, and we do that because we've noticed that the side effects are slightly better. The side effects from sclerotherapy tend to be inflammation in the veins, what we call phlebitis, and irritation, as well as some browning or staining around the veins that were injected, which in some instances can bother people. Here's a preoperative ultrasound. The crosses within these veins indicate reflux or bad valves. And so our sonographer here has identified that we've got blood going in the wrong direction and is feeding this large surface vein down the leg. So this patient, as you can see from this diagram, for this main vein had radio frequency ablation, and then it came back at a second stage for sclerotherapy. And we see in this post-operative ultrasound that everything seems to have been quite well treated, where we have nice closure indicated by the black line of that bad refluxing vein. This is what radiofrequency ablation looks like. A small tube is put in the calf. This device is inserted into that main vein, generally, as I mentioned in the previous slide, the great saphenous vein. This device heats up to about 120 degrees. So to manage that sort of heat in the body, we have to put a lot of cold water into the vein itself. The procedure is sometimes done fully awake or sometimes asleep, depending on the patient's preference. This device goes into the vein. It's all done under ultrasound guidance. We access the vein with a small needle. Once we're happy we're in the right place, we then advance the radiofrequency catheter, and we put in about 6 injections of cold water around the main vein that's problematic. And then once we're happy, we basically then start to close the vein with heat. In my previous slide, I mentioned another procedure called VenaSeal. So instead of heat, we actually apply a medical superglue to the vein to stick it shut. You can see the vein is accessed in a similar way to the previous procedure, but now instead of heat, we're gluing the vein shut. And that has some particular advantages. The main one is it's very low pain. Patients are very comfortable before, after, and during the procedure, and are back to normal activities immediately. There's really no time off required. The main downside is there's a small amount of medical superglue that's left behind in the vein. Per leg, we maybe use around 2 mils to 3 mils to treat each leg. And so I think overall, it's not a lot of foreign material left in the leg, but sometimes people would be concerned by anything left behind. Despite this, RFA and VenaSeal have been compared, and VenaSeal is actually the slightly more durable procedure at around 5 years. This number 1 indicates 100% successful closure, and we can see here that the VenaSeal is the slightly more superior procedure at about 95% at 5 years, with the RFA just under 90% or so. So RFA is a very good treatment, very effective, but not as effective as VenaSeal. And for many people, the decision just comes down to whether or not they want a lower pain procedure, whether they want to be back at work the next day or a few days later, and whether or how they feel about anything left behind. At Melbourne Vascular Associates, we're very happy doing either procedure. We think they're both excellent, and we may make some recommendations based on what we think is more ideal for your particular situation, but we think both procedures are generally excellent and the results are very good. This is what sclerotherapy looks like. This is sclerotherapy done to some smaller, what most people will call spider veins. Medically, we would call these reticular veins or telangiectasias. We sometimes access them with this special light. And here you can see I've got a syringe of a foam called ethoxysclerol, which is basically a detergent-like substance, which is made into a foam and then injected into the veins to get them to close. Some of the larger veins may need to be accessed with ultrasound, and again, the side effects are fairly similar as discussed previously. We may get some firm lumps, we may get excessive browning that we're not happy with, or we may get some staining which takes a bit of time to fully resolve. Now, by and large, despite these side effects and these risks, most people are very happy with their treatment. We just need to discuss all these things with you so you understand what's involved. And the purpose of this video was actually to have you have access to this information before and after the consultation, so you understand what's involved, and so you have a more clear picture about what's entailed in terms of having your veins treated with us. Now, after most procedures, we get you to wear a compression garment for about a week, and then if we're going to treat any larger veins, we may get you to wear it for another week again. So, common questions: do I need to wear a stocking after the procedure? I think I've answered this. The stocking doesn't need to be as intense with VenaSeal. We generally just go to a calf stocking for VenaSeal, and for radiofrequency ablation, we generally do a thigh-high, more firm stocking again for a week. Do I need more injections after the procedure? We sort of include 6 sessions of sclerotherapy within your quotation over 6 months, so don't worry about any additional surprise charges from us. It's all fairly straightforward and included. I would say most people have 1 to 2 sessions of additional injections, and 10% would probably have 3 or 4. It's pretty uncommon to need to come back for 5 or 6 other injections. Is VenaSeal done? What are the item codes? If you want to look them up and check with your insurer prior to seeing us, the number for radiofrequency ablation is 32523 and 32528. The costs vary depending on whether you have private health insurance or not. If you have private health insurance, it again depends on your hospital excess, but the cost may be between $750 to $1,500 out of pocket for the procedure. If you don't have private health insurance, we will provide you with a separate quotation, but the cost would be between $3,000 and $5,000 for 1 to 2 legs. Can I go on a public hospital waiting list? There are some restrictions about who can go on a public hospital waiting list. Generally, you need more advanced vein issues to go ahead, and we're more than happy to place people on the public hospital waiting lists if the out-of-pockets are not affordable or you don't have private health insurance. However, being in a public hospital, we don't really have much control over your procedure and who the surgeon will be. But if that's the way you would like to go, we're more than happy to assist you with that. What are the main risks? Phlebitis, which I've discussed before. This is where the veins can become quite irritated and upset after the procedure. This usually lasts between week 2 and week 4, but generally goes. The stockings can cause a bit of irritation. This is something we'd like to know about, and please call us if you've had the procedure with us and the stockings are bothering you. We may need to check the sizing, and the stockings shouldn't be sore at all after the procedure. There are risks of DVT, and this is where we encounter clotting in veins where we don't want there to be clotting. Why this generally happens, if I go back to this slide here, let's say we've closed this main vein with heat. Some of that heat can sort of extend up into this common femoral vein, and in that case we would probably put you on blood thinners for around 2 to 4 weeks depending on what happens. Now, all patients who have surgery with us or treatment for their varicose veins with radiofrequency ablation or VenaSeal will have a check ultrasound in the week after the procedure to make sure that that has not occurred. Rarely you may have some symptoms which we're not sure about with varicose veins. Now, there's so many things in the legs that can cause pain. We have nerves, muscles, joints, tendons, etc. And on top of that, we may then have varicose veins. In that setting, we may not be sure if the veins are necessarily causing your issues. We may discuss the pros and cons of treating your veins based on that. And so we just need to be aware that in some cases we can't make every symptom better, but your specialist will talk to you about this and give you a more guidance as to what you may and may not expect. Rarely, if you have some more unusual symptoms, we can make this worse. Again, this is fairly unusual, but exacerbation of symptoms can be associated with any vein treatment, particularly for ache or swelling. Now, we do have a more complete consent form that goes into more detail, but these are the main things people will contact us about or ask us about before, after and during. But despite all that, varicose vein surgery is generally very minimally invasive, very successful, and most people are quite happy with the treatment that they receive. Thank you very much, and we hope to see you soon.